is the infection control antimicrobial resistance quarterly webinar for the one scheduled for January. This is the webinar where we tackle topics in either infection control or antimicrobial resistance. So for those of you who had listened into our previous webinar back in October, that was more focused on antimicrobial resistance and stewardship within the lab setting. This time we're very excited to present a infection control focused webinar on environmental cleaning. So the last infection control focused webinar that we had was back in July, and what we did at the end of that webinar was we sent out a poll to everyone seeing what topic you all wanted to hear at our next webinar, and environmental cleaning was the clear winner. So we're very excited to give you some of that content today. So before we get started, I just want to go over some housekeeping. Okay. So my name is Jason Mayer. I'm the Healthcare Associated Infections Coordinator for the Department of Health. So I, along with Patricia Barrett, sort of run these webinars. For the webinar, you will be on mute for the duration. If you have a question, you can type the question into the question or chat box. We'll be monitoring both of those as the webinar is progressing. And we'll have some time to answer those questions at the end of the webinar. If we can't get to your question at the end of the webinar, don't worry. We have them written down and we'll follow up with our speaker after the webinar. Or if the question's for us, we can follow up individually also at the end. This webinar is being recorded. I will throw in the caveat that we have tried to record previous webinars and have had some technical difficulties, but again, we are trying again. So we are fingers crossed, hoping that this one will go through. If it will, we will archive it and have that for you all, and we will send a link off. At the end of the webinar, we have everyone's registration information. We'll be sending out slides from the presenter of this webinar, and we can distribute that in PDF form after the webinar. And then similarly to the webinar that we did in July and October, we're going to have a poll at the end to determine the topic for the next infection control focused webinar. So that webinar is going to be, we don't have the date set, but it will be sometime in the summer, so most likely July, sticking with our twice a year infection control focus and twice a year antimicrobial resistance webinar. So just a reminder also, our spring 2019 webinar is going to be the antimicrobial resistance focus webinar. And what that's going to focus on are overcoming common hurdles in your antimicrobial stewardship program. That date has not been selected yet, but we are still taking some stories and some input from you all to determine that sort of topic. So if you have stewardship challenges or anything that you're working through trying to get your stewardship program up and running, please, you can email myself, which my email's at the end of this presentation I'll be giving you, or you can email our antimicrobial resistance coordinator, Patricia Barrett. Okay, so without further ado, I want to introduce our speaker today. We're very excited to have her, Dr. Claire Rock, who's the Assistant Professor of Medicine at the Division of Infectious Diseases, Johns Hopkins University School of Medicine, and Associate Hospital Epidemiologist at Johns Hopkins Hospital, and core faculty at Armstrong Institute for Patient Safety and Quality. Her research focuses on reducing pathogen transmission in the healthcare setting. She is federally funded for her work and is the current principal investigator for the Johns Hopkins CDC Prevention's Epicenter Grant. Dr. Rock is Vice Chair of Society for Healthcare Epidemiology of America, or better known as SHEA Research Network, and serves on the SHEA Research Committee and Research Director for the High Value Practice Academic Alliance. So we're going to hand it over to Dr. Rock, who's going to be talking about environmental cleaning and some different innovations in that setting. So Dr. Rock, take it away.
Thanks for the great introduction, Jason. I'm just making sure that you can see my slides as I share my screen.
Yes, that's correct, and we can hear you as well.
Okay, perfect. Okay, So delighted to be here just to give you some updates in healthcare environmental cleaning and really some of the innovations that have happened in recent times. And I'm going to give some information about human factors engineering as it comes into environmental cleaning and also some of the novel technologies. And so just a brief outline of what we're going to go through today. We're going to look at sort of the innovators to date, look at the patient perspective when it comes to environmental cleaning, and then focus a little bit on environmental cleaning monitoring and feedback, which I think is really an essential part of any infection prevention program. And then look at some of the other novel innovations, such as surfaces of high-touch surfaces, the involvement of human factors engineering, and the no-touch technology, and also some future challenges. So we're discussing innovation, and I just thought I would sort of think about what actually is innovation. And so it's a new idea, a creative thought, or some sort of new imagination on a device or method. And, you know, when I think about innovation, really what comes to my mind is that in infection prevention, we're daily innovators. And really because we are applying novel findings into our local system. And we're looking at innovative ways to integrate that into the culture of our hospitals. And so I think it's really part of the daily work that we do, and we may not even acknowledge the fact that we're doing this ongoing innovation. And really, when we look at it here, every innovative effort starts with someone expressing how things could be better. Someone else validates that concerns and offers to help. And then we have this teamwork and innovation of culture. And so actually, when you look back at some of the first innovators, Florence Nightingale is one of the ones that really comes to mind. And her principle was really that the first thing that we do in a hospital is do the sick and no harm. And she was really focused on infection prevention and novel methods that she applied in the situations that she was in. But when we look at innovation, one of the things that I feel is really important is the concept of empathy. And it's really the ability to understand and really share the feelings of another and really see things from their perspective and really through their lens. And, you know, without empathy with our patients and with others, innovation and really change in our hospital setting is really difficult. We lose motivation, we have difficulty understanding the importance of our work, and sort of ingrained in that then, we lose sort of sight of what's acceptable or not acceptable for our patients. And sometimes we don't necessarily feel that passion and outrage that we would have previously in thinking about all infections or many infections being preventable, and then questioning how things can be done better. And when we think about the innovation, when we don't have empathy, we really lose our sense of curiosity and questioning and willingness to try new things, even though they may not work, but willingness to try and repeat trying and trying different strategies. And so in that scenario, we're left at this substandard status quo because of the lack of innovation and change. And so one of the recent examples that I came across that was something that really made me feel internally kind of outraged was thinking about these 10 pregnant postpartum women who acquired C. diff. And so thinking about pregnant women going into hospital, having such implicit trust in the hospital and the healthcare workers that are around them, and delivering their baby and getting C. diff. And it just seemed like such a lack of trust or breach of trust for these patients that it really made me feel motivated again about the importance of the work that we're doing in infection prevention, particularly when it comes to the environment, as a likely source here was contaminated mattresses. And so I put this up here just as one method that I see about trying to spread the innovation and the focus on environmental cleaning, and that's through some social media. And so I would encourage any of you, if you have any inclination about getting on social media or publicizing the importance of the work that you do and understanding other thought leaders, I would encourage you to get onto Twitter and just see what's out there, because it's very eye-opening. And so you can see this where I'm discussing about this paper that's recently been published and tagging some of the thought leaders in the area. And this includes the international, there's people from Australia, the US, Europe, and then also the patient advocacy group, so the PEGI Fund that does a lot of work with C. diff. And it got retweeted and a lot of people saw it. How much impact that truly has, it's really hard to say, other than at least it's getting it into people's minds. And so that leads me really to think that, are we focused enough on hospital hygiene? And we really is the royal we, because who essentially is the we? And so we look at the stakeholders in hospital hygiene, and you can see that when you think through this process, there's many different stakeholders involved, including obviously infection prevention, and then government, regulatory authorities, industry, external cleaning companies, the professional societies, insurance companies and reimbursement, and also the organization and facility, who are really responsible for creating the culture to allow patient safety to happen. So many stakeholders in this process, who, when we're really thinking about innovation in this area, all need to come together in some sort of transdisciplinary method to really innovate our area and allow new ideas come to the fore. And so I'm just going to walk through our patient here, Betsy, who I haven't made up a scenario about what's happened to her to get her to this scenario, but she ends up in hospital and gets into her hospital bed. And really, I mean, she's vulnerable. She's relying on those around her to keep her safe. She's lying in her bed. She has all those high-touch surfaces around her, her IV pole, her call bell, her bed rails, her vital signs monitor, and she feels safe. But Betsy may think she's getting this nice area in the green that's free of the bacteria and pathogens from the patient before her, and really thinking that she's concentrating on getting herself well and following all the guidance that she's getting from the healthcare workers. But she may actually be getting what's here in red, right? She may be getting an environment that's contaminated with all the bacteria and pathogens and viruses, etc., from the person that occupied that room and that bed before her. And so what does that truly mean? Well, we know that she would be at significant risk of acquiring any of these different multi-drug resistant organisms, MRSA, VRE, C. diff, multi-drug resistant Pseudomonas and Acinetobacter. And so even by virtue of no other, if all other factors are equal, the prior occupant MDRO status is an independent risk factor for our patients to acquire these organisms. And the risk may actually be even higher than the table that I've shown you. This is a recent paper published by Elaine Larson and her team, and she's looking over 6 years in New York in 4 different hospitals. And she does a match case control study where she's really examining the impact of the prior occupant and the prior roommate. And in this, she's expanding out the other organisms. So she's looking at methicillin susceptible Staph aureus, Acinetobacter, that's multi-drug resistant and non-multi-drug resistant. So she has in this study a larger frequency of outcome, which makes it easier really to be able to show the difference that's truly there. And so you can see that there's 5.8 times the odds of someone acquiring that organism when the previous occupant has had that organism. And you can see with that confidence interval that the true odds may be close to 10. And so this is really pointing to the importance of the environment in acquisition of bacteria for our patients. And also looking at the scenario of the roommate, 4.8 times the odds of acquiring the bacteria that a roommate has in comparison to a similar patient who's sharing a room with somebody who does not have that particular bacteria. And so this just displays it in a table form where the darker black bars are the cases and the lighter gray bars are the controls. And the first set is looking at the prior bed occupant. And you can see the comparison in the difference even looking at the Staph aureus, with about 1.3% of the cases being previously exposed to somebody that has Staph aureus by virtue of sharing the same room on subsequent admission. And so this kind of gets back to Betsy then, and sort of thinking about what are our patients getting? Are they getting this nice green setting that is completely bacteria and pathogen free, or are they getting this red scenario where they're putting themselves into a contaminated situation? And I think this is important because as infection prevention, there's an onus on us to really know and understand this question. And I would ask us all to reflect and think, do we know what % of high-touch surfaces in our hospital or our setting are adequately cleaned? And as I went through these questions, the three little monkeys came to my mind. I'm thinking, if we don't know this, are we trying to block our eyes from trying to understand what really might be there and where we can make improvements? So seeing no evil. And then speaking, so if we do the process of an environmental monitoring program, do we feed that data effectively back to make change? And so who does that data go to? How is it fed back? And how is the change monitored and implemented and supported through that process? And then we can have hear no evil or falling on deaf ears. Are we in organizations where that feedback, either to environmental care associates, nursing, hospital executive suite, and organizational leaders, that feedback is appreciated and acted upon in order to create change and improvement, which is the basis for all of these monitoring plans? And so there's multiple different ways of monitoring the process of room cleaning. We can have the straightforward observation, so somebody just looking at the room after it's been cleaned. The issue with this, while it can focus on the right things from looking to see if something meets hotel standard cleanliness, it may not focus necessarily on the things that are important to us in infection prevention, and because we can't see the bacteria. The other strategy that's infrequently used is culturing, so using plates or swabs or other methods, sponges, to rub over our high-touch surfaces and see if we can get the bacteria that we think may be in the room. And so this is really limited more to a research type setting because it's expensive. It's very time consuming and labor intensive from a microbiology perspective, as they have to be incubated and bacteria grown. And there's also not clear standards on how this should be done. So a lot of when it's used, it's really in the research arena, and a lot of work being done on how to even standardize that process. The other method that's used is ATP system. And this is really a swab that's indicating if there's a high reading or high relative light unit reading, it's indicated that there may be viable bacteria or other organisms on the surface. But those organisms can be dead or can be alive. And so it's not really giving you much information about that surface having the potential for transmission. And the other thing with the ATP system is often it has to be really aligned to be directly done after the cleaning process. And so the logistics and feasibility of trying to do that can be challenging. And also difficult to interpret because the relative light unit threshold of 250 and over that there being opportunity for improvement is kind of hard to relay to multiple different stakeholders, including our environmental care associates who are the frontline people that really need to understand this process. And so the other one that I'm going to focus on for the purpose of the next few slides is the concept of fluorescent gel. And so this is basically putting on high-touch surfaces a dot that is invisible to the naked eye, and then returning some period of time later, usually 24 hours or a little over 24 hours, and using black light to see if the the dot is still present, as you can see here where this black light is shining, or if it's absent. And so if it's absent or removed, it indicates that high-touch surface has been mechanically wiped. And so we would call that surface clean, or at least has gone through that process of cleaning. And the nice thing I like about this method is that it's very easy to use. It's very easy to understand the concept of it being there or not there, and simply indicating that the surface has been wiped. And it's easy to understand to a wide array of our different healthcare workers. And the thing that I also like about it is that when we're doing the reading of the dots, which is shining the black light, that can be an immediate opportunity for feedback and for identifying if there's specific issues with certain high-touch surfaces that are challenging for the folks that are doing the cleaning, and bringing the frontline associate with the person that's doing the reading of the dots to try and understand those issues really gives immediate feedback and immediate information on what may need to change to improve the process. And so I'm just going to go through a few slides looking at implementing a fluorescent gel program, and just some lessons and thoughts that we've learned here, and also some publications that we have in this arena. And so one of the first things I would say is very, very important house-wide, not just with your environmental care associate team, but also with your hospital leadership, infection prevention, nursing, and other stakeholder groups, to clarify the purpose, the expectation, and the goal, and to really have that in a supportive, non-blame environment, so that people feel that if they make a mistake or they forget something, or something happens, that they can bring forward that issue in a supportive environment and have it addressed, because often these issues are related to systems errors, and if one EVC associate is having that issue, many others most likely are. And then I would say is really a thoughtful consideration about the feedback mechanisms, who to feedback to, how to do that feedback, and it's going to be different for the different stakeholders, when or how frequently, and what the purpose is of the feedback that's been given. And that really relates to the role of the person that's receiving the feedback, whether it's the board of trustees of a hospital or the frontline associate, and the different people in between when you're trying to implement change and improvement. And then I would say, based on that feedback, clear action plans. And the other thing that I've put here is really considering the patient role. And I put that because sometimes people, I think, may have an impression that patients think that this is something that is, maybe shouldn't be done, or indicates that a hospital is not clean, or there's some concern. And we are doing this process in our Johns Hopkins Hospital, but also as part of a SPARK initiative, which is a collaborative for preventing C. diff across Maryland, where we're assessing the fluorescent gel removal we've done close to 10 hospitals across the state. And so we don't preferentially pick discharge rooms. We think it all reflects the overall process of environmental cleaning, and daily cleaning certainly plays an important role in that. And so there's a natural interaction with the patients when we go into the room and explaining about the process of environmental cleaning. And so I asked some of my the staff that are doing this, what the response has been to patients, and it's actually been overwhelmingly positive. Those that are interested in the concept like to know that this is at the fore of the hospital, and that it's considered important in the hospital, and they feel somewhat reassured that they're having this extra monitoring in the room. So it's an interesting piece when we think about how the patient can be involved in monitoring programs. And so then the other things that I'm going to run through quickly is who is best situated to do a fluorescent gel monitoring program. How many rooms, how many high-touch surfaces should be done, how to pick the rooms, and then as I've sort of really just discussed, the daily versus the discharge, or both. So who to do it? So there's lots of different potential healthcare worker roles that could be the one to implement a fluorescent gel monitoring program. And there's advantages and disadvantages to each one. You can think about the infection control practitioner or somebody on the infection control team and being the person to actually operationalize the fluorescent gel monitoring. And you can see that that would be resource intensive, and infection preventionists, certainly we don't have enough of them and are already overtasked with many other important tasks. But you can see some of the advantages. Infection preventionists, as you all know, understand the overall mission and are really usually very experienced in giving constructive feedback and understanding the system and making change. The other role that could be involved in this is the unit nurse. And so the advantages of this would be that it can strengthen the EVC nursing collaboration if it's done properly, and really have a joint ownership of patient care. It can really help delineate the high-touch surfaces that are nurse responsibility and the high-touch surfaces that are EVC responsibility. And this is really important, particularly during the daily clean, where it can happen that some of these really important around the bed areas are not really getting addressed by anybody because there's no clear responsibility for who is accountable for what. The data can be discussed at the unit level and really owned by the unit. And then having a unit nurse do it means that all shifts can be monitored because there's the convenience of having a nurse or somebody on the unit that's there. Some of the disadvantages, obviously nurses have many different competing priorities, and there may be a need for multiple different nurses on each unit if someone wants to try and be able to get a spread across the different shifts. So next we can look at the EVC supervisor and think about them being the person to implement the fluorescent gel and actually do the dotting and the reading. And so the advantages, there's direct accountability. Normally the frontline associate is accountable to the supervisor. And the feedback can also identify systemic problems, as one supervisor is usually looking after many different units. Some potential disadvantages, they may have more vested interest and may not necessarily be objective and shared as widely as it should be, and data may not necessarily get communicated back to the unit. Let's think about the EVC associate themselves as kind of a self-monitoring type of program. And so the advantages here, they would take ownership over the task and performance improvement. We know it's very difficult to self-monitor though. And peer-to-peer monitoring is also difficult. So I think some work would have to be done with this to really have it in an environment where change can happen, and there's a non-blame type of environment. And then thinking about some of the lessons we may learn from hand hygiene. What about a secret shopper or some of our healthcare workers that are on leave from occupational health who can't go about their usual duties? Could they help implement this fluorescent gel monitoring program? It certainly could reduce, if there was any Hawthorne effect, it could reduce it. And the process is relatively simple, so it wouldn't need a lot of training. But then on the disadvantages, the validity could be compromised, and it may be ineffective to do a lot of training if there's a lot of turnover. And the last thing I'll just mention about who is best positioned to implement the program is thinking about a mixed role. So could there be nurse and EVC associate? And that really gets back to the idea of the daily room cleaning and being the responsibility of both, and a joint accountability model. So the next thing I'm going to look at, we've looked at who, some options for who should do it. And then the next thing I'm going to look at is how many. And so it's how many high touch surfaces and how many patient rooms. And what this really is a tipping balance between the resources and the time that we want to put into doing a fluorescent gel monitoring program, and the output that comes from that to allow performance improvement to happen. And so you could imagine in the 100% ideal world, every single high touch surface in every single room would be monitored every single day, and the feedback would happen to every single EVC associate at every time. But obviously that's not feasible. It's too resource intensive and really not feasible. So where is this tipping point that we're getting as much information as we need to be able to understand what's happening across the unit level as a whole, but we're not overdoing it and putting more resources in than we need to. So really getting bang for the buck. And so what we did here is we did, over a period of a few weeks, many, many high-touch surfaces. So close to 3,000 high-touch surfaces in over 200 randomly selected rooms in 13 units in our hospital. And so you can see in the second column there, we just have some of the high-touch surfaces. And basically what we did is we took that as the gold standard. So this was the maximum that could ever feasibly be done. And then we looked at different sampling strategies. So what if you looked at just one high-touch surface per room? Does that reflect what the overall fluorescent marker removal rate is for the rest of the cohort? What about 2 high-touch surfaces, 3, 4? What about 1 high-touch surface in the bathroom and 1 in the main room? And the really interesting thing that we were able to show is that 3 random high-touch surfaces from 2 random rooms, and I'll just discuss a bit about the random on my next slide. But basically, that's enough to reflect the overall fluorescent gel marker removal for that unit as a whole. And so you could imagine if you've 1 or 2 associates that are doing a unit, this is a good method or a good way to think about how to implement a program where you're really getting maximum output for the least amount of input that you can do. And these 3 random high-touch surfaces in 2 random rooms holds true if the overall fluorescent gel removal is good, so over 80%, or poor, less than 80%. And also can reflect the daily and discharge clean. So what we would say for this is to randomly select the rooms independent of whether you know there's going to be a discharge that occurs or not. And I think that's important because a lot of our time can be spent trying to coordinate which patient is going and getting into those rooms and spending time outside those rooms waiting for an opportune time to go and do the fluorescent dotting. And this really takes away all that logistical piece by just randomly selecting the rooms independent of the type of clean that's going to be assessed. And so we haven't published this data yet, but I think it's going to be, well, I hope that it's going to be helpful if people are thinking about implementing plans and maybe thinking that it's a bit more resource intensive than it truly needs to be. And so we've gone through the number of high-touch surfaces and the number of rooms, but which rooms to choose. And so you can have the method where someone goes up onto the unit and is like, okay, I'm going to pick 2 rooms, which we would call convenience sampling. And so you can imagine that this is subject to lots of unconscious bias even by the most well-meaning of people that are doing this process. But there's a bias to oversample non-contact precaution rooms because people are most likely, if they're just going to choose 2 rooms, to choose one that they don't have to gown and glove up in and they can just go into. And more likely to oversample rooms where the patient isn't present. And so this is interesting because we know from some of the future work that I'll show you later in the talk that when the patient is present in the room, in the bed, it's much harder to get at those important high-touch surfaces close to the patient, like the bed rails and the overbed table, etc. So it could be falsely giving an opinion of falsely higher removal rates if we're oversampling rooms where the patient is out for multiple tests and not present in the room. There could be the oversampling of the same rooms, the one that's close to the door, close to the nurse's station, etc. And then there's that goes hand in hand with the potential for Hawthorne effect, where it may be known that certain rooms are done more often than others. So I would introduce you to this research randomizer, which is a very simple tool that's available online and goes through very quickly how to use it. And basically what you can do is you can list the number of rooms that you have and then basically press a button and it'll randomize. And so someone can go up onto unit with that sheet printed and they have a random list of room numbers and they basically progress through those until they get the required number of rooms where the dots are placed. So that's where I'm going to finish up on the fluorescent gel monitoring and sort of thinking about what are some of best practices when we implement a program. And I'm going to go back to the patient and think, okay, what are the different strategies that we can use to prevent the environment playing a role in transmission of pathogens to our patients. And so I'm going to discuss a little bit about the patients themselves and methods of decreasing the bioburden or the bacteria specific from that patient from contaminating their surrounds. Discuss a bit about different types of surfaces and methods to stop adherence of pathogens and otherwise onto those high-touch surfaces. Speak about manual removal and disinfection, which is obviously the most commonly used method for hospital cleaning, and then touch on no-touch technologies. And so the first thing, thinking about the patient and decreasing their pathogen shedding, well, the first thing would be all the work that's been done about getting patients outside the acute care setting. And so with the knowledge that sometimes it's not the safest place for them to be for all the reasons that we've outlined. And so there's a lot of artificial intelligence being done, and there's a concept now called wearables, and that's been FDA approved, and basically it monitors all vital signs. And so there's hope that this concept will help decrease the number of patients that need to be admitted into a hospital by having early outside the hospital intervention. And then, as we're likely familiar with infection prevention in our antimicrobial stewardship colleagues, is care in the home. So things like outpatient antimicrobial therapy, where we're really moving patients out and trying to prevent admission into the acute care setting. The other thing, as we all know, the cornerstone of infection prevention, hand hygiene. And the interesting piece about this is that there's a recent study looking at the patient, and actually hand hygiene of the patient can prevent environmental contamination of the surfaces around the patient. And it makes sense. Often it's their touch or their hands that are touching the bed rails, the overbed table, etc. And so there's multiple reasons for thinking about hand hygiene for the patient, but this is one other benefit of using a strategy such as that. And then things like CHG treatment or keeping the bioburden of the skin down, and then looking at device-related things. So for a ventilation system, when that suctioning system is closed, you don't have the large spray of respiratory pathogens into the environment and that you can have during a closed suction. And then looking at basically the pathogens on the surface. So anti-adhesives, contact active, biocide release. And so let's just look a little bit into those with just a few slides. And so the first concept of it is anti-adhesive, and the lotus leaf picture there on the top is a natural anti-adhesive where it's repelling water from absorbing onto his surface. And there's two strategies for this. There's polyethylene glycol and hydrogel. And a lot of work being done in this area about how it could apply to surfaces within the hospital setting. Then another type of surface that there's been work done on, and this is to do with quaternary ammonium and antimicrobial peptides, AMP. And there's lots of work being done in the biochemistry arena to try and see about how these could be used. And this includes a concept called the spacer effect, which is basically the biocidal part, so the antimicrobial peptide perforates the bacteria and goes into the site by going through the cytoplasmic membrane. And this is enhanced by this polymer chain and these polymer brushes, and that can help really keep up the activity of the quaternary ammonia and try and decrease the chance of the bacteria getting resistant to this process. And the other thing that we're hearing a lot about in other areas of medicine is this concept of bacteriophages, which in the simplest of terms are basically viruses that infect bacteria. And this is used a lot in food industry and food treatment for preserving food. And there's been some work done on different surfaces such as gold, glass, cellulose, hydrogels, and this concept of bacteriophage and how they could be used. I'm going to touch a little bit on the concept of the biocide release. And so these are the antimicrobial metals that we may have heard some about. So the ones that are widely used are copper, which I'm going to focus on a little bit, silver. And then we have titanium dioxide, which uses sort of a photosensitizer system to activate. And so copper has actually been recognized by the Environment Protection Association for 10 years as having really significant antimicrobial properties. And so when a surface has greater than 70% of copper in its formation, there's marked decrease of C. diff, vegetative, and spores. And this is really, when they do studies looking at the greater than 70% versus lower copper concentrations or stainless steel, the improvement seems to remain with the more copper that's in the surface, the better. And basically what happens is the copper releases its ions, and that affects the membrane or the wall integrity depending on the positivity, the gram-positivity of the bacteria, which allows for an oxidative stress in the bacteria and cell death. And really one of the advantages of this seems to be that there's low level of resistance among clinically relevant microorganisms. And really the only copper resistant type mechanisms that are seen are with microorganisms that are living in really copper rich niches, such as like mines or marine sediments. One of the exciting things, and I just have the reference below here that's being looked at, is basically using a copper-based composite to cover high-touch surfaces in a liquid form. And so this would be not specific surfaces, specific equipment that needs to be made, but rather a copper-based surface that can be poured over the high-touch surface. But what we truly really need to really understand if there is true clinical effectiveness is large cluster randomized trials to look at the effectiveness. And there's many limitations to that, including the fact that patient-level randomization has significant limitations. And it's really because for a trial such as this, it really needs to be randomized at the unit level. And because the benefit is not just to the patient in that room, but the benefit may be to other patients also in that unit because you're preventing onward transmission to them. Looking at the titanium, this is a single study done in a European ICU, and they actually did not find any reduction of microbial colonization of environmental surfaces. And I highlight this because then you have another study done in South Korea where they found marked reduction in MRSA acquisition and post-introduction of titanium dioxide controlled high-touch surfaces. Interestingly, in this study, there was no impact on multidrug-resistant Acinetobacter or VRE. But just to say that it most likely depends on the scenario of the pre-existing scenario and the pre-existing effectiveness of the manual disinfection and removal, and that's ongoing prior to instigating some of these other methods. And so I'm conscious that I have a short few more minutes, but I really want to touch on the manual removal and disinfection because this is truly the cornerstone of hospital hygiene and environmental cleaning for our patients. And what I will introduce you to is the concept of human factors engineering as it pertains to hospital hygiene and environmental cleaning. And this diagram is the Systems Engineering Initiative for Patient Safety, which we adapted for this process of patient room cleaning. And it really looks at the work system, how the work system contributes to the process of patient cleaning and how those processes can contribute to the outcomes. And so I'll focus your attention on the largest square to the left of the screen. And you can see in the center is the people, and this is the critical piece. And the people stakeholders in this process are the environmental care associates, the patients, the families, infection prevention, other healthcare providers. But we can see the interaction between all the different areas. So the tools and technology, how important it is that people have what they need, the supplies that they need, and that those tools are adequate to do the job that needs to be done. And also looking at the task and cleaning the high-touch surface, is there adequate training, et cetera, for those for that effective cleaning to be done. And so human factors engineering is in the definition that's from the International Ergonomics Association, is the scientific discipline concerned with understanding interactions with humans and other elements of the system, and applies theory and other methods in design to optimize human well-being and overall system performance. And so the interesting thing about human factors engineering, when we think about applying it to hospital hygiene or environmental cleaning, is it can be simplification. And so this is a study done from in the UK, where they basically introduced one wipe system. So one strategy, one wipe, not multiple different disinfections. And so they were looking at MRSA and found that there was significant reduction in their MRSA acquisition in a pre-post type setting after introducing this disinfection wipe, which was a novel wipe, but also the process of having one as opposed to multiple. And to me, this sort of lends weight to the concept of us in the US, where we already use disinfection type of wipes, but thinking more about the concept of universal sporicidal and thinking about how complex are we making it for our environmental care associates to get a C. diff effective product to where it needs to go. And so thinking about simplifying the process and having, the fewer disinfectant types that we have, the less room there is for human error. The other thing that has been looked at with human factors engineering and innovation in this arena is color. And so this is a highlights wipe that was born basically from the Ebola doffing procedure, where the spray for the doffing disinfection, they added color so they could see exactly which part of the personal protective equipment was sprayed and where was yet to be sprayed. And so this company have now used that same type of technology, and they're using it to implement in the hospital setting. So looking at how the impact of color can help. And so this is the use of color into some of the disinfecting agents, and therefore it's a visual guide as to how much of the high-touch surface has been cleaned. And also what they have is that it changes color when the adequate contact time has lapsed. And so a really helpful visual about contact time. I'm going to turn our attention a little bit to some of the other work that's been done looking at human factors engineering and the process of patient room cleaning. And so this is based in a participatory ergonomics model, which is basically means if you want the problems to be, know what the problems are and have them addressed, you need to get to the front line and truly understand from their perspective what the issues are and have them be part of the process to come up with solutions. And so what we did was some observations of the cleaning process, some semi-structured interviews, and then some focus groups. And so this is some of the results just looking at daily patient room cleaning. And so you can see that there was a red area, which is around the bed. And I'll come back to this in 1 minute when we think about the training and the workflow that's most important for our EVC associates. And there was many interruptions and a lot of interaction with patient and family member for the EVC associates, and a lot of difficulty in getting to around the bed area, particularly on the daily clean. This shows link analysis, which is basically looking at that same process, but seeing how are they going about the process. Do they have a systematic way of going clockwise or counterclockwise or others? And about a third were using a clockwise method, but close to half were using this horizontal vertical, which is sort of an up and around, and so may not be the most efficient or effective when we think about the process of room cleaning. And then the interview process brought up lots of great factors that could be worked upon to really improve the process and the effectiveness of room cleaning. Stuff to do with the people, the experience of the EVC associate. And one thing that came up loud and clear in many of the observations and talking that we've done is the tools and technology. And we've seen this on multiple other assessments of other hospitals through the Spark Collaborative, but the availability of carts or brooms or mops and disinfectants and whatever else is needed for the EVC associates to get their jobs done is a problem that is in many places. And so thinking about that and really how we can give people the tools that they need. I sort of liken it to coming into work and not having a computer and then having to go around to different offices and try and either hoard a computer for myself from the night before or take one from elsewhere. And that's what's happening in the reality for many environmental care associates. And then looking at the interaction between the patient and the family and the organization. And so what we did then was basically got all the EVC associates together into these focus groups where we explained to them the results of the observations, what they had brought up in the semi-structured interviews, and looked at some strategies for improvement and asked them to list them in the top 3 that they thought was most kind of important to change. And I'll give you just a little snapshot of a few of the pieces that were picked. So I discussed a bit about the carb preparation and some of the solutions that came up with for trying to make this easier for people. So a designated person to be in charge, labeling and color coding of the carts, and sort of a link so it's clear which cart is on, should be located on which unit. And this is to emphasize the whole focus of the participatory ergonomics. So this is a short video that one of the frontline EVC associates is the speak-over voice, and I won't show it to you, but it really goes through the whole process of what they're required to do. And then the other piece on the right is a one-pager that's a similar type of process. And what we have is a group of environmental care associates that are going to the huddles and discussing this work with their peers, and really letting it be known that these issues are being addressed based by the feedback from the front line. This is looking at some other areas that were identified, so such as leadership, communication, identifying an EVC team liaison and facilitator. Another thing that was identified was the feeling of teamwork and inclusion on the unit. And this is one that we've done a lot of work in, trying to make EVC associates and nursing and really strengthen that relationship and collaboration between those 2 groups, so everyone feels empowered to speak up and communicate their needs, and we can get more effective room cleaning done. Performance evaluation. There was a need for a lot of face-to-face communication about this, and I think the fluorescent gel monitoring program that we discussed really can help with that. And the piece that I just want to spend 1 minute speaking about is these areas of workflow and training. And so we had identified from the multiple other parts of this study that the area around the bed is really one of the areas that's not cleaned adequately. And there's multiple issues related to this. But what we did was we reorganized the checklist, which was not in any particular order for the high-touch surfaces that the EVC associates need to clean. And basically, we have it that the bed area is the first area that they do. And this is also because if you've ever observed a discharge cleaning being done by an expert environmental care associate, the bed is quite a physical endeavor to really clean a bed properly, the mattress, the bed rails, etc. And so while it's the most important, we thought, why not put it there at the beginning when the person is entering the room and they're freshest, and they can really make sure that their energy and attention is on that task. And then looking at basically the other high-touch surfaces and focusing on the other high-touch surface. And the piece that really goes hand in hand with this for the daily clean is the patient communication. So the interaction with the patient to allow for around the bed adequate cleaning. And so this is just a sort of a larger version of what we're implementing for workflow and really focusing on those high-touch surfaces. And sort of with the knowledge that not all surfaces are equal when we think about it from infection prevention perspective. Hand in hand, like I discussed, is some scenarios about looking at the patient and family interaction with the EVC associate. And we did some role plays and some real world scenarios about how we could tackle this. And what I will say is that all this that I've spoken to you about has been brought together into a toolkit which we're working on with the CDC, and will include a lot of these communication tools and workflows and novel checklists. So coming online at some stage near you. Jason, I have a section on no-touch technology, and then I have a short wrap-up. I don't know if you want me to continue with those, or if there's a lot of questions coming through that we want a few minutes to address.
Hi, Claire. I think if we could give people a moment to, if anyone has any questions that you want to have addressed right now, please type it into the question box or the chat box. Right now we have one question in the chat box asking, is there some form we can use for screening environment for infection control issues? So I don't know, Claire, if you want to try to tackle that. We have some forms at New Jersey Department of Health for, that's not really a master form for environmental issues, but you know, we can reach back out to the person who's asking the question as to sort of do on a case-by-case basis. We can give, you know, whatever forms are needed. There's no kind of net master form. But Claire, I don't know if there's any forms that you guys have that you use.
Yeah, we have forms to try and understand the system. So basically some prompting questions to ask the environmental care associates. And we also have, we do some observations of rooms and have sort of a quality assurance type form for observation. But certainly there's tools out there that are available, and I'd be happy to share what we have.
Awesome. Okay. We're also going to launch the poll for the next ICAR the next infection control focused webinar, so that before this webinar sort of closes out, people have the chance to get their voices heard for the next webinar topic. So Claire, I think we're gonna have to swing it back over to us.
Sure.
We only have a minute or two left. But I definitely want to thank you for such a thoughtful and engaging presentation. Very informative, and I think everyone's going to definitely want to take a look at some of those slides, because there's so much in terms of content there. It was definitely very informative. So thank you so much for helping us and presenting on this webinar.
No problem. Thanks for the invitation.
Yes, yes. So, Claire, is your contact information listed on your slides?
Yeah, I have it on the last slide with my email and Twitter handle, and so yes. Okay, perfect. So when we send out, we'll send out that information as well. So the poll right now is active. We have 4 options for the next infection control webinar. If you want to also write in, you can email myself or Patty Barrett if you feel like there's a topic that isn't included in this poll that you want to see covered on a future webinar. Please email us. And again, if you have questions, even if we can't get to them in time now, please type them into the question box, because we will be following up via email or phone call with the answer to those questions, and we can't. We don't know what you guys aren't asking if you don't write it into the chat box or the question dialog box. While we are waiting for the poll results to come back, again, I just want to thank Dr. Rock for presenting here. I want to thank Laura Taylor and Krista Riel for helping put on this webinar. Without our health educators here at the state, webinars like this would not be possible. So thank you. And of course, our ICAR team, the Infection Control Assessment and Response team, many of which you know already, who have been out in the field helping, doing the infection control assessments and helping put on these webinars and presentations. So right now we got about 64% voted. We're going to give it a couple of additional seconds. Right now it's basically neck and neck between sterilization, disinfection, and transmission-based precautions. Again, if there are other topics you would like to see covered, please email. We are about at time right now, so we're probably going to end the poll, and we will get back. So right now it looks like the next topic will either be sterilization, disinfection, or transmission-based precautions. We will let you know which topic we end up covering on the next infection control webinar. I do want to just remind everyone that in April, our antimicrobial resistance webinar will be going live. We don't have a date specific for that yet,
but it will be talking a little bit about building up your antimicrobial stewardship program within your facility. So definitely looking forward to that. Again, if you have any questions, please in the chat box or email myself or Patricia Barrett, and we will get back to you. So we have a lot of questions that we will have to get to. Right now it is 12:02, so we're probably going to have to get back to these questions through email or through personalized phone calls back to you guys. So thank you so much. We're going to be keeping an eye on these questions, and we're going to have to enter the end the webinar now. But we'll be getting back to all these questions. So I can continue to urge to answer, to put your questions in the webinar box. One question that I can answer for everyone right now is there are no credits for this webinar, but we thank you for asking, and that's something that we possibly can look at in the future. But right now there are no credits offered, and we will email the slides again. So thank you everyone for attending, and we look forward to our next webinar. So thank you.